Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss-Studienprogramms, Marcus at Home welcomes Professor Borge Nordestgaard in Copenhagen, Denmark, with whom we would like to discuss pathophysiology, diagnosis, and treatment of hypertriglyceridemia. Thanks a lot, Borge, for being with us this afternoon.
Thank you so much for the invitation.
Borge Nordestgaard is Professor of Clinical Medicine at the University of Copenhagen. Among many additional academic positions, he is chair of the Copenhagen General Population Study and steering committee member of the Copenhagen City Heart Study, which may be coined the 21st century's Framingham studies because of their global impact on epidemiologic cardiovascular research. Few days ago, he received the 2022 Anishkov Award, which is the most prestigious award of the European Atherosclerosis Society. He is one of very few researchers with more than 1,000 publications. And we were honored to host Dr. Nordestgaard last September for our Marcus at Home live event here in Frankfurt, Germany, when Dr. Nordestgaard reported on LDL cholesterol. And today we meet him virtually to discuss his other main focus of research, namely hypertriglyceridemia, which has, as you have wonderfully shown in an introduction figure to a circulation research paper some years ago, recently come back into clinical focus when it comes to understanding atherosclerosis. It's always a privilege to meet you, Borge, and it's a particular privilege this week when Copenhagen sees the departure, or Le Grand Départ, of this year's Tour de France, which is also the starting point for our cardiorenal Tour de France 2022. Together with our new academic partner, la Société francophone de néphrologie, dialyse et transplantation, we plan to meet 4 global leaders on 4 weekends in 4 cities that will host this year's tour from Copenhagen to Paris. And I'm honored to have 2 Francophile co-moderators, Florian, Custodis, cardiologist in Saarbrücken on the German-French border, and Sarah Morell in Frankfurt. My name is Gunnar Heine.
So I'd like to start the interview with a patient presentation. And we have a 33-year-old male who comes to you. He says that he's healthy, but that his GP noticed some weird lab work. So he shows you the lab work and you see that the cholesterol is 187 milligrams per deciliter, the HDL 45 milligrams per deciliter, the LDL 70 milligrams per deciliter, and the triglycerides are 362 milligrams per deciliter. So you ask a few questions, he tells you, oh, he likes to drink and party a bit, like 8 drinks a week or so. But otherwise he's healthy, yeah, no history of cardiovascular disease. He doesn't really do lots of sports. He has no diabetes. So how would you proceed with this patient?
Well, I mean, certainly talk a little bit more into his lifestyle. I would guess he could also be overweight or even obese. And if that was the case, I know you have to talk about lifestyle because he's such a young person. So I mean, generally the high triglycerides is an indicator of you have some lipoproteins that cause atherosclerosis. But this is, of course, over many years. So I would do whatever I could to try to have him cut down maybe on alcohol intake and also calories in general to lose a little bit of weight, just to tell him that long term, if he has this very high triglycerides, this is not very good. I mean, it increases the risk of cardiovascular disease long term, but I think at such relatively high levels, if he keeps going drinking so much, he might also get a risk of acute pancreatitis, which is not a very nice thing to have actually. So I think at this stage, I would not go for medical therapy for him. I would definitely talk about lifestyle.
Great. So let's stay on the topic of hypertriglyceridemia. How do we define this disease, as the cutoffs arguably very arbitrary in literature?
Yeah, I think so. It's as I said, most of the focus has been on the risk of acute pancreatitis. And so like historically, the European guidelines have said that if triglycerides is above 880 milligram per deciliter, which is about 10 millimoles per liter, the Americans actually use half that value, roughly 500 milligrams per deciliter, which is about 5 to 6 millimoles per liter, then the risk of acute pancreatitis is high. And then there's a lot of debate about doing something about that. But in reality, the level probably has to be quite a lot higher before you have real high risk of acute pancreatitis. I would say now that there's evidence that as soon as triglycerides go up, the risk of acute pancreatitis goes up. But then for many years also, we've been aware that if triglycerides are maybe from about 2 millimoles per liter, which is about, 170 or something milligram per liter, and anything above that, really, the risk of atherosclerosis and thereby atherosclerotic cardiovascular disease, including myocardial infarction and stroke, is increased a lot, as much or sometimes even higher than if LDL is high. So there's a low limit above 2 millimoles per liter, 180 milligrams per liter when you think of cardiovascular disease, and somewhat higher levels, not completely clear when the risk of acute pancreatitis is really high.
Mm-hmm. And why do plasma triglycerides levels follow such a skewed distribution as shown in your large epidemiologic data from 2016?
Well, why is always a good question. I mean, I can say that's the way it is. As you said, there's this skewed distribution with a tail toward very high concentrations. And some things in epidemiology or in human life are just log normally distributed. So if you log transform it, it becomes a normal distribution. Whereas other things like LDL is normally distributed. So exactly why? It must be something to do with the metabolism, either the influx or the put into the plasma of triglycerides from the intestinal liver, and when you take it out again. But sort of like the exact explanation why this one is skewed, whereas LDL and HDL are normally distributed, I don't know for sure. Probably something to do with you get a lot of triglycerides into the blood, and then it is degraded very fast by lipoprotein lipase to these smaller particles, eventually LDL particles. So maybe that is something to do with it. It's something that comes in degraded, whereas LDL is more like an end product of the degradation of the triglyceride, which is the proteins being more normally distributed.
My last question would be, what causes hypertriglyceridemia? You've talked about obesity a little bit and about alcohol intake. What are other causes?
But there's no doubt when we look at it observationally in epidemiology, then the most important driving factor for hypertriglyceridemia is overweight and obesity. It explains a lot. And then, of course, diabetes also, but that's also part of being overweight and obese. But diabetes per se also does it. There's genetic causes for it. People do that. There's some other things also. And if you think of the really, really high triglycerides, the one that comes to the attention of the doctor when you have like triglycerides, let's say, of, 10,000 milligrams per deciliter or 1,000 milligrams per deciliter, something like that, then it is usually, first time it's dysregulated diabetes mellitus. Some patients that are undiagnosed or does not follow the prescriptions. Secondly, really high alcohol intake. And then there's actually some genetic forms, some rare genetic forms of lipoprotein lipase deficiency that explain these really high levels. But for the lower levels causing cardiovascular disease, overweight, obesity, and diabetes, they account for a lot.
So when discussing physiology and pathophysiology, you co-authored a very nice recent European Heart Journal overview consensus paper, which nicely shows the two ways that triglycerides may get into the body. Either they come from enterocytes or they are secreted by the liver. So which part of the triglycerides may be attributed to this enterocyte secretion and which part comes from the liver?
Of course, all the fat that we eat is taken up in the intestine and then secreted in the enterocytes as chylomicrons that then come into the blood, and then they are quite fast degraded for most people unless you lack this enzyme, lipoprotein lipase. And then it's taken up by the liver, and then the liver produces the VLDL particles that has triglycerides in them also. So immediately after a really fatty meal, you can have quite a lot of triglycerides from the intestine. But even in that situation, the liver so fast take up triglycerides and put out VLDL again. So even there, it is still the liver-derived triglyceride lipoproteins that quantitatively are the most important.
You told us that people who have regular alcohol intake do have higher triglycerides. Do we know exactly which mechanism stands behind this?
Exactly, there's different ones. I mean, certainly one thing is that alcohol, if you drink too much alcohol, you get a lot of energy from it, and then the body cannot store alcohol, the energy from it, so the liver cells changes into triglycerides, and then it comes into fat tissue where it is deposited. So that's, you know, that all if people drink too much, they get particularly the men, we get this belly, right, from drinking too much beer, actually. So I would want to say just a little bit about alcohol and high triglycerides now. I'm not quite sure that the high triglycerides you get from some alcohol intake does cause cardiovascular disease if it's solely the triglycerides elevation. These lipoproteins need to have both cholesterol and triglycerides in them, and that's what you see much more when you have obesity and overweight. So yeah, I hope I answered your question.
So then comes the elephant in the room. How does actually hypertriglyceridemia may cause atherosclerosis? So are the triglycerides themselves to be blamed for these effects, or are fatty acids playing the major part, or is it just the cholesterol which is kind of hidden in these particles?
I'm not in doubt. When you take the totality of evidence, it is the cholesterol content in the triglyceride lipoproteins that cause atherosclerosis. And this for the simple reason, when you look at atherosclerosis, take it out from a dead human, a person, it's actually cholesterol that physically makes the atherosclerotic plaque. It's not triglycerides. There's no triglycerides in there. So you could say that the larger triglyceride lipoproteins compared to LDL only, they both have triglycerides and cholesterol, and they can come into the arterial wall. They become entrapped, being taken up by macrophages. The macrophages can degrade triglycerides, also proteins, but not cholesterol. That's the whole point. We don't have enzymes in the body that can degrade cholesterol. That's why it stays in the arterial intima and thereby cause atherosclerosis. Triglycerides could make the triglyceride lipoproteins worse than LDL because triglycerides is degraded in the intima, maybe at the surface. And when you get free fatty acids, these will be toxic to tissue. So it seems that the triglyceride degradation could be part of why atherosclerotic plaques sometimes are more inflamed than others and thereby more prone to rupture and cause myocardial infarction. But atherosclerosis per se, that's cholesterol.
So it's actually comparable to what LDL cholesterol does, also invading the intima layer and then starting the development of a plaque.
Exactly.
So there are people who have very high triglycerides, say 2,000, 3,000 milligrams per deciliter, and they will not develop atherosclerotic disease. So apparently having mildly elevated triglycerides seems to be worse when it comes to atherosclerosis than having very high triglycerides. And these people are apparently rather affected by pancreatitis. So do we understand what makes the difference between these two kinds of people?
Yeah, we do. I mean, when you have extremely high triglycerides, the lipoproteins are really large, the size of chylomicrons, and then they are just too large to enter into the arterial intima, and thereby will not be able to cause atherosclerosis. I should put a caveat though, that even if you have very high triglycerides, then some of these patients sometimes sort of like fluctuate in triglycerides, and then sometimes they come down in the lower range where they cause atherosclerosis.
Borge, one question I have, talking to patients and getting into dialogue about triglycerides, I always try to explain why we store triglycerides, and I always try to come along with the story. Well, genes from our ancestors very long time ago, and they were we need it, or they needed it to store energy for a couple of days or so. And the patients come and ask me, well, why is it that we still have those genes? And you're a professor of genetics, and maybe the question is stupid, but even me, I was always asking, well, why is that?
No questions are stupid. And why do we store triglycerides? Well, it's, I mean, I think historically as human beings, we have not been able to eat 3 meals every day as we do now. So I'm sure that the persons that were able to store some triglycerides while food was abundant, they better survived when food was scarce. So I think that's probably the most important thing. And then maybe also human beings, particularly us that live up north where we have tough winters, then some fat around the body is very good for insulation, and you probably survive it if it gets very cold. So these two purposes are really important, I think. So I think interesting here, actually, that people, for example, of Indian descent, where there's been so many famines historically, and people have died from not having enough food, they tend to, now that there's so much extra food available, they have much more problems with high triglycerides and atherosclerosis because of that, and also diabetes. Maybe because the ones that survived in India are the ones that are very good at keeping the fat in the body. So just a thought, really.
Just getting back to our patient Sarah introduced, I think in the clinic we have to tackle 2 questions. One is acute risk for complications like pancreatitis, and you told us about those cutoff values. So that's different between US and Europe. And the second is to predict risk and to even reduce risk. To just briefly, how to tackle the risk of pancreatitis. What's the role of dialysis or even apheresis in this context? Or are there pharmacological ways of doing or getting to a reduction very fast?
Yeah, so I mean, if you have high risk of pancreatitis, of course, the best you can do is to try to convince the patients to lower the triglycerides by lifestyle changes. But I'm not saying that the patients are told about that should never have any drugs. So if you try for a while with reducing alcohol and maybe losing weight, and if that does not help, then I would certainly consider maybe some drug therapy to keep triglycerides lower. If you're so unlucky that you have this very high triglycerides and you do get acute pancreatitis and get into hospital, then I think apheresis is a very good thing. And I know in Germany, for example, Austria, they would use that a lot. That's a very relevant thing in the acute phase to get triglycerides down. Usually most patients, if they get acute pancreatitis, they will stop eating themselves because of the tummy ache, and then triglycerides falls automatically. Then if you think sort of like without the phase where you have acute pancreatitis and you want to prevent it long term, I think particularly relevant for the ones with chylomicronemia syndrome and maybe the genetic forms with lipoprotein lipase deficiency. There you have to, the best thing to do is actually to let them get in contact with the dietitian that can help them to really cut down any fat in whatever they eat. You see, they don't need fat because there's plenty of fat in the body. So they should be on a strictly non-fat diet, which is very difficult to do. But that's the best you can do it. There's a particular situation when you have pregnant women that have tendency to high triglycerides in the 3rd trimester because of the extreme high estrogen. They get very high triglycerides, and there you certainly can do that for 3 to 4 months to keep the fat down very much. But I don't think you would apheresis frequently. The problem is that there has been several attempts, but we don't have something very good drug right now to reduce triglycerides. There is one on the market from this American company called Ionis or Axia, and what it does is that it goes in and blocks the production of ApoC3, and then triglycerides goes down. but there's also some side effect with it. There's new generation being developed and more drugs. So maybe in 3 or 4 years time, we'll have lots of much better drugs with no side effects. But for now, it's a bit complicated. Yeah.
A great point. And again, the first step and the really the greatest corner in therapy is lifestyle. And
exactly.
For the discussion with the patients, I think this is a major and basic concept.
But you agree with that caveat, if triglycerides is really high, so like 1,000 or 10,000 milligrams per deciliter, then you need to go to some real intense dietitian advice of no fat in the diet, which is different from the usual thing: lose weight, cut down on alcohol, and eat a bit less fat. Yeah.
Just getting back to our patient, what can we do to characterize risk? What other kind of lipid parameters should we measure? Should we measure VLDL? What's the role of LDL in that context? What can we do to characterize cardiovascular risk in patients with high triglycerides?
Yeah, so I mean, if you follow the guidelines, and also my advice, a full lipid panel, which usually entails total cholesterol, total triglycerides, LDL cholesterol, and HDL cholesterol. But then you should also calculate 2 more things. And we do that for all the labs in Copenhagen, actually. You can calculate what's called non-HDL cholesterol, and you can calculate what's called remnant cholesterol, or what you say maybe VLDL cholesterol. Because when you look at the totality of cholesterol, you have HDL, which is neutral for atherosclerosis, LDL, of course, causes atherosclerosis. And then the remainder cholesterol is what I call remnant cholesterol, which is what is found in the triglyceride, which we put in. So I like to look at all 6 values. The guidelines, particularly the European guidelines from ESC and European Atherosclerosis Society, they say that you first drive down LDL, and then you also look at non-HDL cholesterol, or maybe even ApoB. And with non-HDL cholesterol, ApoB is high. This is just telling us cholesterol in the triglyceride, rich lipoprotein. So at the same time, triglycerides will be high. So that's usually what I look at. I want to be sure that the cholesterol that is not in HDL or in LDL is also being brought down. That's the most important. And of course, that means also you bring down triglycerides. But for the future, at some stage, I think the focus should be on cholesterol in these particles.
If I think of many patients and looking at lipid panels, what you always get to the point that LDL is rather low in this.
Exactly.
And you mentioned guidelines, and the guidelines say, well, that first tackle LDL cholesterol, use a statin to reduce risk.
Yeah.
It's kind of different from a clinical view to really accept that there's LDL and that LDL has to be tackled by a statin. Why is that LDL often is rather low in this constellation with high triglycerides? Oh,
but that's a physiological phenomenon. This is because of cholesterol ester transfer protein. So if you have a lot of the triglyceride lipoproteins or remnants in plasma, then the so-called cholesterol ester transfer protein, or in short CETP, will exchange. It will take triglycerides from the remnants and put it into LDL and into HDL, and then it would drag cholesterol out of HDL and LDL into these other particles. So it's a natural physiological phenomenon. So if you cannot get rid of the triglyceride lipoproteins, LDL cholesterol and HDL cholesterol will be lower. And therefore, it is not enough as a clinician to just look at LDL cholesterol, because you can even get it very low if triglycerides is very high. And then you have to make sure to get remnant cholesterol or non-HDL cholesterol or triglycerides down if you want to prevent cardiovascular disease in your patient. So would you say that statins are the mainstay of therapy in people with accelerated cardiovascular risk? Yeah, of course. I mean, statin is phenomenal evidence-based medicine. There's not much else in the medical literature that is better shown that if you give a statin to a patient, it reduces cardiovascular disease, myocardial infarction, stroke, and people even live longer. So of course you want to use statins. There's no doubt about that.
Okay, so that's lifestyle and statin. There's some other drugs on the market, and there are omega-3 fatty acids, of course. They're quite popular, and they're kind of over-the-counter drugs, even in Germany. And 2 years ago, there was kind of a debate, and some arguments were exchanged about two trials, which is Reduce It trial and Strength.
Mm-hmm.
The question was if omega-3 fatty acids could reduce risk in people at high cardiovascular risk on top on statins.
Mm-hmm.
Could you just briefly guide us through this arguments and this discussion?
Yeah, definitely. So all the former omega-3 fatty acids, they were sort of like similar to over-the-counter fish oils, where you only get maybe 1 gram of omega-3 fatty acids, so quite a low dose. And when you take all these studies together, there's no evidence that it reduces cardiovascular risk. And then came the Reduce It trial that used 4 grams of EPA. Is one of the omega-3 fatty acids. And in that study where omega-3 fatty acids EPA was compared with mineral oil, there was a huge difference between the two groups, a 25% risk reduction on top of having a statin. So this was like a revolution, almost too good to believe, you could say. And then a little bit later came the Strength trial, which also used 4 grams of sort of like purified omega-3 fatty acids, so much higher dose than the older studies. And that was compared to corn oil. And then suddenly there was a completely null effect. So therefore, some people argue that it's because it was EPA only in the Reduce It trial that you saw this 25% risk reduction. But others would say that part of the effect could be that the comparator oil in the Reduce It was mineral oil, whereas the comparator oil in Strength was corn oil. Corn oil probably had a little bit positive effect, and mineral oil could have a little bit deleterious effect as it increased both LDL cholesterol and CRP. So it seems like there's some effect of EPA, but maybe not the 25% risk reduction, because some of it could be explained by different comparator oils.
So direct question, what side are you on? A third study, a third trial, what comparator would you use or would you prefer?
Yes. So first of all, my side is evidence-based medicine. I look at the data and the totality of data and try to interpret them the best possible way for the benefit of patients. So that's my side. But I think there would be a need for, I doubt it will be funded, for a study that probably compared EPA as used in Reduce It with EPA plus DHA in Strength trial to see if it was really true that EPA alone is superior to the combination. Or you could say that EPA as used in Reduce It trial should have another study compared to corn oil. Either of these trials would be a fantastic to sort of like solve that. You could call it a bit of a mystery, really.
So we met Dr. Nissen last year, who was first author of the Strength study, and he was very skeptical when it comes to accepting the finding from Reduce It, because he clearly stated that the findings from Reduce It have been explained not by benefits by taking the omega-3 fatty acids, but because of disadvantages of the comparator, so again of mineral oil, because mineral oil did increase both C-reactive protein, CRP, and LDL cholesterol. So you would have adverse effects if you have been in the placebo group with an increase in inflammation and an increase in LDL cholesterol. Now, you went back to your Copenhagen data and tried to find out in how far these effects upon LDL cholesterol and CRP may help us to understand the findings of strength versus reduce it?
Yeah, so it's to try to tackle this question differently. We took our large Copenhagen general population study with 110,000 individuals, and then we took out selectively the people corresponding to the ones that were recruited in reducer trial, respectively in the strength trial. And then we could see that if we looked at what was the reported effect on LDL cholesterol, triglycerides, and C-reactive protein as either bringing more inflammation or less inflammation in all the four arms, so in the comparator oil arm in reducer and the EPA arm in reducer, and in the comparator corn oil arm in strength, and the active oil EPA plus DHA. And then we tried to see how much could be explained of the totality of the effect by changes in LDL, triglycerides, and CRP. And then we could see that of the 25% risk reduction observed in reduce it between the two arms, a reasonably large part of it could be explained by deleterious effect of mineral oil, and some part by a beneficial effect. But I think about 8% or something we could not explain by this. So this could be explained by something completely different. This could be a beneficial effect of EPA, but it could also be other deleterious effect of mineral oil. Whereas in the strength trial, when we looked at the lipid effects or CRP effects on the comparator oil corn oil and the EPA DHA, they sort of like together could explain the effect observed, namely a null effect. And if anything, we would suggest there would be a small benefit of EPA plus DHA, actually very similar to the EPA we could document. But this was a mimicking trial, so of course it's not as strong evidence as the real trials.
And there were some side effects of these high dosages omega-3 fatty acids, like an increase in atrial fibrillation and increase in bleeding. So they do not come without risk, and surely they are quite expensive, which I think makes it even more difficult to decide for us whether or not to use this. And I think most doctors in Germany are rather conservative and do not use these drugs too often because we are not really convinced by the evidence. But so we may have some novel drugs in the future, which will surely also be very expensive in the first years at least, to which you already alluded to. So the ApoC3 inhibitors, the NGPLT3 inhibitors. We have not really good data on these omega-3 fatty acids. So should we still use fibrates in some patients?
I mean, there's no doubt in my mind. I mean, if you have the patient with hypertriglyceridemia despite on a statin, the first thing I would do if I want to give more drugs is to make sure that the statin is atorvastatin 80 milligram daily or rosuvastatin 40 milligram daily. So the most potent statin in the top dose, because they can reduce remnant cholesterol and triglycerides by up to maybe 40%. So that's by far the best. And then I still am convinced that if you only give the fibrates on top of statins, the ones that have still high triglycerides, the totality of evidence for me suggests that that will be a benefit for the patient. So that's what I advise. And then, as I said, I accept all the evidence. So some doctors may choose to use EPA on top of it, some may not.
Are there any particular combinations of statins and fibrates that you would prefer or that you would recommend us to avoid, because there may be quite significant interactions between these two classes?
Yeah, I mean, but you just want to, and the interaction you're referring to is mainly that the risk of muscle aches and of course long-term rhabdomyolysis is slightly higher when you have this combination when not. So, but I don't think that is much different from any other patients that get on a statin, particularly because these days there's so many patients that come and complain about muscle ache, because if they Google it, you know, it's just enormous amount of, in my mind, nonsense about side effects of statins. Most of it is just in people's head. So if you give the combination, of course, you should again talk with the patient about muscle aches, but it's not muscle ache in one arm because you played tennis last day, or your legs are hurting because you started running and you never ran before. It's a universal muscle ache, so like strange feeling in the muscle. That's what you're worried about. So, but I'm not worried about that. Just talk with the patient about it. That if you get this universal muscle ache, then you should be thinking about it. But that's it. I'm not worried at all.
And one of your more than 1,000 papers actually nicely points out that whenever national television programs or national journals pick up this topic, then compliance with statins will go down, while whenever there are positive news with regard to statins in national television, then people are more eager to take their statins. This is one of the many convincing papers that you have published in the last years. So my last question on treatment, and this is maybe an easy question for you living in Scandinavia, what about fish intake? So we asked this question also Dr. Nissen. Dr. Nissen was not really convinced. He answered us that the major benefit from fish intake may be, if any, that we eat less of our sausages and stuff like that in Germany. I guess the Scandinavian view on this may be somewhat different.
Yeah, I mean, as a normal just person living in a society, I guess in my mind just make the totality of evidence, and I fully Dr. Nissen's argument that then you don't eat something bad in the meantime, you don't eat burgers or sausages. That's of course a valid argument. But otherwise, as I see the totality of evidence for fish intakes, it seems to be very beneficial. So what do I do personally? I eat fish several times a week. So, and this, I think this is sort of like evidence-based up in my mind what I do. So I can strongly advise that's a good idea. Not necessarily just to reduce triglycerides, but simply because there's no evidence saying that fish intake is bad for you. It's good for you.
What can I recommend to the GP? Well, we do not have target values, don't we?
Nope. Well, yeah, we do indirectly because of the non-HDL cholesterol. Okay. So the non-HDL cholesterol you want to bring down, and when non-HDL cholesterol is high and LDL is low, it is because of the triglyceride which were proteins. But you don't have a target directly for triglycerides. But non-HDL cholesterol, I hope some of the laboratories in Germany report non-HDL cholesterol. We report it always. So it's so easy to look at, right?
And would you recommend what level of reduction would you tell the GP he should aim for? 50% reduction in non-HDL, or
yeah, I think it's better that I try to advise corresponding to the main European guidelines from ESC and EAS that are converted into German guidelines, I'm sure, and then they don't use the percent reduction so much anymore. They're much more for get down to a certain low levels, and you know how low you want to get. For example, LDL cholesterol depends on your absolute risk. So if you put the same absolute risk, and then you can accept non-HDL cholesterol be about maybe 20 milligrams per deciliter higher than the LDL goal, then this is fine. But you know, in general, if you have a patient at high risk, it's just bring LDL and non-HDL cholesterol as low as possible. That's what I usually advise.
I have to ask you one final question on diagnosis, because this is also always a question and discussion between different doctors. For routine clinical practice, would you advocate us to use fasting blood draws or non-fasting blood draws when it comes to measurements of lipid parameters?
Non-fasting, of course. I mean, we introduced that in Denmark in 2009 as the first country, and everybody uses non-fasting in Denmark. So the two big reasons. The one is that it is so much simpler for patients, for laboratories, for doctors. And the other argument is that in the non-fasting sample, just a random non-fasting, there's a better chance you will capture the high triglycerides and remnant cholesterol. So of course, non-fasting. European guidelines and the main American guidelines, they say that non-fasting lipid profile is perfectly fine.
So thanks so much for this academic input. And now I pass the mic back to Sarah Morell.
I have a very last question for you, and it's a cultural one. So our stop of the Tour de France is in Copenhagen. Which places should we visit? If you name 3, where should we go?
I mean, definitely there's a lot of places. Copenhagen has a big variety of things that are very interesting to do, but I can choose some different ones depending on what people like. I think to go to the Tivoli Gardens is fantastic. People think it's an amusement park, but it's not really. It has some amusements in it, but it's a park with beautiful flowers, with free concerts, with some of the best restaurants in Copenhagen and the Tivoli Gardens. It's just it's overwhelming what the things you experience when you go in there. So that's a fantastic visit. If I should go to the other end, something that is actually very close to Tivoli Gardens. I like art myself. So there's an art museum called the Glyptotek, which was originally built by the founder of the Carlsberg breweries. And all the money he made from serving beers to Danes, he put into art. So he built this fantastic art museum next to Tivoli Gardens with wonderful things to do and a small palm garden. And then I think a third thing I could suggest, which is completely different. There's this free town in Copenhagen called Christiania, which was an old base for the Navy had the quarters there, and then they moved out. But when they moved out, they forgot to lock it up. So a lot of squatters, they just moved in and they stayed there for free for many, many years. And so there's a free town where people live there. They do apply to Danish laws, but for many years they didn't even pay rent, or they didn't even pay for gas or electricity. But now they do pay for gas and electricity, but not rent anymore. And I think it's a wonderful place. I take visitors there because there's also restaurants there. There's shops you can go into, and most of the hashish sales in Copenhagen happens there. But you don't have to buy hashish, right? But there's so many different things. Also cultural things. They have concerts. It's very, very different from the Tivoli Gardens. But then there's many, many other things. There's castles. There's other museums. There's parks. Beautiful places.
So I'll have to go. I haven't been yet.
So thanks so much, Borge. It was, as always, a privilege and a pleasure for us. The tour will go back to France. Next week, we plan to meet Professor Giré in Lorraine next Friday, when we discuss another very important issue, namely diagnosis of cardiac decompensation in patients who come to our emergency departments. Hopefully, we may meet you one day again in Frankfurt. Thanks so much, Borge. Thank you.
Yeah, it was a great pleasure and honor. Thank you so much to all the 3 of you.